any other part of the world who's here. If it's morning, good morning. And I did two things in this lecture. One is I'm talking generally about light and how we use it in optometry, and also how it affects our patients in optometry. And then at the end, I added a whole section just about blue light, because I know that's a very hot topic right now. So I have quite a few slides. A few of them I'll go by quickly. I just put them in there so you'll have them for reference later. But I hope we can get through it all. And if I'm speaking too quickly or anything, just let me know. So there are three biological pathways of light. We obviously know vision. Some people are familiar with the non-visual optic pathway that is through the eyes, but goes to hypothalamus and is for our circadian rhythm, or our sleep-wake cycle. And the third is photobiomodulation, which is a term that is now being used for what was called low-level laser therapy. Then it became low-level light therapy. It's primarily red and near infrared light being used therapeutically. So in this picture, and it's a mouse model, but it's very much the same in humans. I just thought this picture had some nice touches to it to be able to understand it better, which is basically what I said, that we have light that goes from the eye, and in our case, it regulates our pupillary responses. It does regulate our circadian rhythm through what's called the suprachiasmatic nucleus. And we know that it goes to V1 in occipital cortex, and then travels in both the ventral and dorsal stream for sight. So it's all written out there for you. And then the influence of light on the circadian rhythm also then plays a role in health. And just here, I'm going to briefly mention, but there are many more slides later, that blue light plays a major role in influencing the circadian rhythm, because these intrinsically photosensitive retinal ganglion cells, the ipRGCs in our retinas, are maximally sensitive to blue. And so there are concerns with artificial lighting, especially LEDs, that have a substantial amount of blue and therefore pose an increased risk of interfering with our circadian rhythm. So we know that there are at least 5 subtypes of ipRGCs. We're not going to really get into that, but we do know that they allow the light to come into the eyes and then project their connections to hypothalamus. But also, we do know that they project toward other areas of visual cortex and therefore influence visual perception. And I know there's some research going on how they are also maybe now involved in some aspects of sight as well. And Dr. Ray in 2012, if you ever have a chance, there's something called the Lighting Research Center, LRC, and I think it's either lrc.com or lrc.org. He's one of the major players there, and they do tremendous work on lighting and aspects of light and how it affects health. And they have some wonderful things on their website that are all free that are really quite interesting. But he basically found, as is now known, that the photoreceptors were maximally sensitive around 500 nanometers, which is turquoise. But we know again that they're maximally sensitive in the blue end of the spectrum. And so photobiomodulation, I said, used to be called low-level laser therapy or low-level light therapy. It uses primarily you can talk about it in the entire visible range, but primarily you will see it being used in the red and near infrared. Although there is some work now being done in the blue end as well. But the major work that's been done has been with red and near infrared. So what are the important things for us to think about? Well, what are the light sources? How are we placing the light? What's the color of the light? And what's the important dosage of light and exposure to the light? Sorry, I keep hitting this by accident. My computer's sensitive. And when we look at that, it's a consideration for any kind of light therapy that we use. One, because too much can be detrimental. And sometimes we've even found that the proper reaction happens in a small range. Too little is no good, as well as too much. And you start to get effects that go up and then start to come down. So we'll take a look at that. So basically in all this, all I want to say here, and it's just here for you to have the information, is there are a couple of people that we should know about. Andre Mester was someone who was involved with initially using lasers to destroy tumors, but what happened was they weren't powerful enough to destroy the tumors, but he noticed that incisions healed more quickly, and his was a ruby laser. And then Tina Carew, if you ever want to look up Tina Carew, is a Russian biophysicist and has done a tremendous amount of work on light, and basically in this case found the effects of light on cellular metabolism. And what we really came down to from all that is that most of it is happening in the mitochondria, especially with an enzyme called cytochrome C. There's it's not cychrome, it's down here correctly, cytochrome C oxidase. So if you ever see things about that, you'll know that it's talking about this cycle and the energy production in the mitochondria. So what light can reach our cells, I think, is important, because it does penetrate our skin. But what you need to understand is that blue light doesn't get much beyond the epidermis, the top layer of the skin. Red light can get down even further, and near infrared penetrates the most. That's why I think in the photobiomodulation, you're seeing the red and the near infrared use the most. If you go into the far infrared, though, you start to get less penetration, which is kind of interesting. But the blue doesn't go very far, but still can be useful. And the red and the near infrared are what you're going to see the most in devices right now. And for biostimulation, the monochromatic light is necessary. So LEDs are used because we can get individual LEDs of certain colors, or we can easily tune them to be different levels of color, or even different levels of white light. There are tunable LEDs that can go from the more yellow light to the very white light. And there are tunable LEDs. And in fact, here now we have a lot of light bulbs that don't even need any kind of hub, and you can use an app on your phone, and they are tunable to any of 16 million colors. Anything that's on the CIE, we can do. So different colors are used for different purposes. We talked about the red and near infrared for photobiomodulation. What you will see, though, is that there is amber used more in aesthetics, and green and blue can be used for acne and chronobiology, so looking at helping with timing. And the other is, I have seen sometimes for acne, I've also seen that they have masks that go on the face that are different colors. So it may be that they can tune it to what's best for you. And then in dentistry, they use a lot of ultraviolet, especially for sterilization. And we've also known for many years that 5,500 Kelvin, Kelvin is what's called color temperature. If you have 23 or 2,500 Kelvin, that's that more yellow light you get from an incandescent bulb. And 5,500 is a much brighter white you tend to get from fluorescent and of course now LED. And we know that that bright light at the proper time of day can help with what's called seasonal affective disorder, something that we have here more in the winter when we have less sun, and depression. So what are the applications for optometry? Well, migraine headaches, certain retinal conditions, inflammation, non-24, which we'll talk about in a minute, attention deficit hyperactivity disorder, traumatic brain injury, athletic performance and recovery, and anti-aging medicine. So here in Boston, there was some research going on by this Rami Burstein, who's at Harvard here, and he found that migraine sufferers reacted well to a narrow band of green light. And so he found that it was helpful to use this. And in the beginning, he was just using, I think, some either LEDs or some small green bulbs that he found. But I'm going to show you in another slide, they now have a lamp, a company that produces a lamp with that particular green. And so they found, interestingly, that blue light was hurting migraine patients who were blind. And that's when they thought about the abnormal sensitivity to light during migraine. Now, some patients who are blind, depending why they are blind, can still have working ipRGCs enough to react to light, but not see. And so he found again that the green tended to hurt the migraines much less. And they used ERG and VEP to look at these cone-driven retinal pathways. That's the reference on the previous slide. And so this is somewhat more about the soothing effects of the green light. So thalamic neurons, which are more involved with pain, were least responsive to green. And therefore, they found that the green could be used for these migraines. And this is the lamp. I don't know if it's available there. It is here. It's called the Allay lamp. And basically, most of it has this green light. And where it looks white on the light here, I don't know, it's hard to see in the pictures on their website, but the light can be used as a regular lamp. So I don't know if it's a strip that's white or if internally it just changes from green to white. But in any case, they've made it so that patients can have something that's pre-made like that. I will say that for some people, it's a little bit expensive. So we certainly are talking with patients about other light bulbs that are out there that could produce the same type of green and that are much less expensive. But I think it's nice that at least there's a product out there and now it will get more recognition. So many of you may be familiar with the FL41 tint. It was developed in part by a neuro-ophthalmologist named Kathleen DeGray here in the US. She was actually trying different tints with patients for blepharospasm. And while it may have helped the blepharospasm some, they found this sort of pink to amber color that was helpful for headache. And so this is just showing you its transmission compared to a neutral gray lens. And you can see that in that sort of blue-green end, you have some attenuation. And here is from a company called Axon Optics. And Axon Optics, I believe, is her company, or she's involved with it. And they have eyeglasses you can purchase on the web, non-prescription, and they can you can send them your prescription. And also they just in the last maybe month apparently can now do contact lenses. And I don't know how they do that. I don't know if you send them clear lenses that the patient will wear and they tint them, or whether they have some type of set that you test with patients. It's so new that I haven't seen any information on it yet. But they claim about 38% decrease in light sensitivity, decrease in headache days, and it works, they say, 87% of the time for the users that they're certainly looking at who have purchased their product. And then there's another company here called Theraspecs, and they have a number of different lenses, but again, they have an FL41 and they have some that are photochromic, but basically their basic lens blocks about 80%, again, in that range that tends to worsen the migraine. And that's just the FL41. And this is from something called Reticare, which is I believe that it's a filter that you place on your computer. And again, here we have a lot of what are called blue blocking lenses. I will say that, and you'll see later how much blue they really block, but these are just the curves of several of the early blue blocking lenses. Gunnar Optics, their particular lens was really just marketed as something to use at the computer, although that is where we talk about it a lot, but these other ones have been talked about for all kinds of devices. So what about macular degeneration? Well, they did find that when they tested different levels, different peaks of light on subjects' eyes, and then they looked at best corrected visual acuity, contrast sensitivity. They were able to measure the drusen volume and the drusen thickness. And basically, what they found is that in patients who were exposed to these multi-wavelength LEDs, so they had all these colors and near infrared in them.
Hi, doctor. How are you? Doctor, I need your help, doctor. Please, my lens, please push them to get it faster because my eyes are...
Okay, can you hear me better now?
Yes, doctor.
Okay, I'll turn my sound up too. So what they found was that patients had a better visual acuity, better contrast sensitivity, even the drusen volume decreased and the central drusen thickness decreased, which is pretty amazing. Now, maybe some of you have heard of what is now being called non-24-hour sleep-wake disorder. Some people just call it non-24. It used to be called free-running circadian rhythm. And basically, it's someone whose circadian cycle doesn't follow the normal sleep-wake cycle. And what happens is that their sleep-wake cycle is generally longer than 24 hours, or what you find is they adjust their sleep-wake cycle to the length of the day, but it sometimes can go around the clock. So if they sleep, let's say from midnight to 8 a.m., then the next night they can't fall asleep until 1 a.m. And then the next night it might be 2 or 3 a.m. And it keeps going like that. And so it turns out that most people who have this non-24 are blind. And the reason is because if they are not able to have light go through these intrinsically photosensitive retinal ganglion cells, they're not getting the proper stimulation for regulation of the circadian cycle. But you should know that they do find that there are sighted people who have this as well. And basically, in terms of treatment, light therapy may be a potential treatment. The only study I could find talked about 2 case reports that if patients had morning light exposure, similar to what we do with seasonal affective disorder, that they could entrain the circadian rhythm. That's what it's called when you get it to its normal 24-hour circle. It's called circadian entrainment. But they had to have the light therapy for several hours a day. And these are the references for that under there. And here, there's a drug called Hetlioz. It's made by a company called Vanda, V-A-N-D-A Pharmaceuticals, and it binds to melatonin receptors. And they don't know the precise mechanism of it, but it has been marketed very heavily here to bring more awareness of non-24 and also to let people know that there is now a pharmacological treatment. Because interestingly, I think a lot of doctors are not that familiar with non-24, or these patients are often misdiagnosed. So melatonin, many of us may be familiar with. You know, in the ipRGCs, there is a chemical called melanopsin, but what's produced is melatonin, and melatonin has to be higher at night, and it has to be suppressed during the day in order for us to be awake. And so some people do take melatonin in the evening to help with sleep, but it has to be really in very low dose, because if not, you will be tired all the next day. Now, in terms of traumatic brain injury, in 2019, they looked at light therapy for a condition called CTE. CTE is chronic traumatic encephalopathy. It's a condition that's hard to diagnose while someone is alive, but they do know that when they've examined brains of athletes in particular, who sometimes prior to their death show a lot of psychiatric issues and other kinds of things, that they are diagnosed with this CTE, and they can see these changes in their brain. And what they've been finding is that light therapy can be helpful for that. And you'll see in a minute, it has potential, which has just come out in the last year, also for Alzheimer's disease, which is an accumulation of tau in the brain. So Margaret Nasser is someone who's been known here for many years. She originally talked about using red light on acupressure points on the wrist for the type of issue that people have with repetitive injury, so that when they're on the computers a lot and they have wrist problems because of repetitive doing that task repetitively, that was helpful. But what she was looking at in 2019 were, again, two people only, but 2 retired professional football players that, based on their medical history, they thought might have CTE. And they found that light therapy was helpful. An fMRI in one certainly showed changes. And when they stopped light therapy, one man found that his symptoms returned. And so he purchased a device, or was given a device to use, called the Vielight Neuro Gamma, which I'm going to show you a picture of. And the interesting thing in this case is there's a little information here about it, but I want to show you the picture. This has not only light that is over the top of the head, but there's a piece that goes into the nose as well. And you can see here, it's one side of the nose. And I don't know if how they make a decision about which side of the nose, or if it matters, but there have been a couple of devices out there with light just through the nose, because the tissue there is thin, and obviously there's a connection to the brain. But in this case, some of that light is, you can see on her forehead here, is also through the skull. And there has been a lot of research going on about using light therapy through the skull, especially for brain injury. In fact, one of my patients was in a study here in Boston. She doesn't know if she actually got it or didn't get it, but she was part of a study. And so again, here's a little bit more information about it for you. But basically, one of the things patients have to be careful of when they use any near infrared devices is there isn't going to be much of a color to the light, because we know that we can't see the near infrared. So they have to put maybe a little bit of red there so you can see it, but it's not going to look very intense. And the biggest thing was that some people became sleepy because it correlates with alpha brainwave activity. So in Parkinson's disease, sleep disorders are common, and light therapy reduced that excessive daytime sleepiness. It also improved sleep quality. People didn't awaken during the night, and they were more alert during the day. And in some cases, they also found that the motor symptoms that people have with Parkinson's were improved, meaning less, with the light. In Alzheimer's disease, this is pretty new research. They found that gamma oscillation brainwaves are important for memory, retention, and attention. And they could stimulate them by exposing, in this case, mice to light, flickering at 40 cycles per second. And that helped eliminate the buildup of amyloid and tau proteins in the brain. And what they found was if they combined it with sound tones that were beating at the same frequency as the light, then the stimulation went beyond visual cortex, extending as far as hippocampus. So we know that this is likely to be something that will be studied more in humans. And in terms of anti-aging, for anyone who's had a few birthdays out there, red light therapy is often used in aesthetics, meaning when they're working with you on a lot of skin issues and issues around wrinkles in the face. And they did find that LEDs, red LEDs, could produce new collagen and elastin in the skin. It's safe for all skin types. And they found a lot of improvement in the tone and texture of the skin, even after one session. Now, for those of us who work a lot, sometimes we have chronic neck pain. Maybe we're not always sitting or standing in the best position, and when we're bending over to do ophthalmoscopy and other kinds of things. And so there is a newer device out there called the LumaWave. It's infrared light, and it can be, I'll show you the picture. This is what it looks like, and this is what it looks like when you just put it on your body. But it tends to warm the muscles and joints and deep tissue areas. Remember, we talked how near infrared can get into lower levels of the skin. And it stimulates cell regeneration and promotes some of the biochemical restorative processes. I actually know one of the neuroscientists who worked on this, and she's not with the company anymore. She's working on another project now, but pretty interesting stuff. And this is just some information about the device if you had an interest, and this is showing it. So now what I wanted to just take another maybe 10, 15 minutes to go through is about blue light, because it's really become a hot topic. I don't know there as much as here, but here over the last maybe 5, probably not even 10 years, there have been a lot of doctors recommending to patients what they call blue blocking lenses, especially if they spend a lot of time on devices. And I want us to think about Is that necessary? Is blue light helpful? Could it at times be harmful? And so let me go through this. So we know that blue light's important to visual processes for color perception. Obviously, we've talked about circadian entrainment and also for the pupillary light reflex. What are the hazards, if you want to call it that, of blue light? Well, we do know that too much blue light on the retina can cause photochemical damage. And we also know that blue light suppresses melatonin. Well, that's important early in the day because we want to stay awake. But if you're in front of a device, for example, that is giving off a lot of blue light that is in the range of melatonin suppression, then it can be a problem because it may affect your sleep-wake cycle. The other thing they found that in areas where there is a lot of extraneous light at night, so for example, if you live in a city and you don't have dark curtains on your windows and there's outdoor light from some type of street light or signs on buildings that happens to be on during the nighttime, that you may be more at risk for breast or prostate cancer. So I just want to show you here, so you'll remember it as we go along, that when we're talking about macular degeneration, the peak sensitivity is around 435 or 440 nanometers. But the peak for melatonin suppression is 465. And you'll see why that becomes important. So macular degeneration around, we'll call it 435, melatonin 465. Now, we know that incandescent lights, which are going away, have little short wavelength light, but newer light sources like fluorescent lighting, our cell phones, our tablets, a lot of LEDs are much richer in blue. And the interesting thing here is that one of the optical companies came out with charts and all kinds of things, calling it high energy visible light from 400 to 500 nanometers. Now we know that it has more energy. We know that's why it can have more effect on the retina, but I think they're trying to scare people a little bit when they say high energy light. Also back in 2014, they were talking about blue light causing damage to the back of the eye, and we're using more LED lights. And they said by 2020, 90% of all our light sources would be LED. Well, here that's not quite true, partly because you can still get some incandescent. People tended to buy a lot of the bulbs when they knew they'd be going away. And not everyone has changed over in terms of lighting that's already in place in homes, in offices, but it's certainly going in that direction. Now, what happens when we age? Well, we know that the transmittance of blue goes down as we age because the lens has an increase in something called lipofuscin, and lipofuscin blocks the blue. So while we're talking about blocking blue and maybe it's harmful, one, you can see that if the lens is allowing less blue, and it turns out that more people who are phakic than aphakic or have intraocular lens implants develop macular degeneration, is blue really the thing we have to be worrying about? But again, as the lipofuscin accumulates, the blue light decreases, so there's certainly less blue light hazard to the retina. Now, there are what are called blue blocking intraocular lenses, and they do eliminate anywhere from 43 to 57% of violet and blue light. But while it may be more protective of the retina once you don't have the lens with all that lipofuscin, we do know that it may have a negative effect on how you see color, and on circadian photoreception, on the circadian rhythm. So they did find that the violet blocking lenses allowed for better scotopic sensitivity and melanopsin photoreception, but I don't recommend them to patients. And they did find that sometimes the best thing really was when they were in a place with a lot of light or a lot of blue light, that they were better with sunglasses. Again, because most macular degeneration occurs in phakic adults who are over the age of 60, not necessarily in those that have had intraocular lens implants. And again, here's a study that suggests that blue light in old age is more important in the development of macular degeneration than earlier in life. They're saying because of a decline in macular pigment density. So there has been a push here for us to get an instrument and measure macular pigment density in patients, and then to recommend supplements that will bring their macular pigment density up. And I generally am recommending that patients over the age of 40 or 50, even without a test, take some of these products, because unless they would be taking them in high doses, there's no negative effect and potentially a positive effect. The other is that there were 2 studies that did find an association between macular degeneration and environmental light exposure, but 6 other studies found no correlation. I think the other is we're putting a lot of attention on the devices that people are on. And we'll talk about a little more about that in one study in a minute, but we need to understand that if I'm sitting in front of my computer or looking at my phone, I'm probably not doing it for way extended periods of time, except now during COVID, when sometimes I sit a whole day listening to conferences online. But you also can sit back from it a certain distance and therefore getting less. And generally, if we go outdoors in the sun, when we have sun here, but you have much more of it there, we definitely know that we get probably 100,000 times more exposure in a short time outdoors than we get when we have that exposure to devices indoors or even any type of indoor lighting. So I think what's important is, if someone is out in the sun a long time, I would recommend good sunglasses, and especially if you're at higher elevations. But do we need all this protection indoors? You can decide. Well, we do know, again, that short wavelength can produce retinal damage. We don't really know that in real populations of people that that's really a reason to think that they're going to potentially develop macular degeneration. And again, if long exposure to outdoor light is not causally related to it, then indoor light, which is orders of magnitude weaker in blue and ultraviolet, cannot be the culprit. So again, we already talked about circadian rhythm. I just kind of put it here because it's part of the talking about blue light. We know that we need melatonin, so we need less blue at night, but we need melatonin early in the day. We need suppression of melatonin early in the day, and that's where the blue light can come in early in the day, because the ipRGCs are maximally sensitive to the blue light. So it turns off the signals from the ipRGCs and it suppresses melatonin, therefore we stay awake. Which also can be a bad thing, in that artificial light will also keep us awake at times when our body naturally should be sleeping. So at night, melatonin is released and then what happens is that if we're during that time on artificial light sources like computer and cell phones and anything that may be emitting a lot of the blue wavelength, it's going to suppress melatonin, and we need the melatonin, not only for sleep, but it happens to be a very powerful antioxidant. And so it kind of flushes our system at night. And there have been a number of articles lately, and I think we'll see more about the importance of sleep to a lot of disease processes. So is melatonin the principal controller of sleep? And they're saying no, because otherwise we'd be asleep as soon as it gets dark. And obviously we postpone that in some when we turn on lights or television, but they do say that sleep deprivation and disorders of sleep long predate this blue light suppression of melatonin. So it may not be the main thing that affects sleep, but it does play a role. And again, I think more importantly is as an antioxidant, we certainly want to have it at night and suppress it during the day. And what about e-readers or tablets or anything that you may spend time on your computer screen as well? I think they looked at e-readers like a Kindle or something along those lines, or a Nook, or I don't know what you may have there. But any type of tablet that you're doing a lot of reading on. And they did find that with 25-year-old volunteers, that if they read for 4 hours, I don't know who has 4 hours before they go to sleep, but they reduced their evening sleepiness. It took longer for them to fall asleep. They had less REM sleep, and it took longer for them to feel alert in the morning. One of the authors of this study is a gentleman named Charles Czeisler, who's really been studying this for a long time. He started off many, many years ago studying shift workers, and I respect his work, but I don't think too many people are going to spend 4 hours on their device. Although again, during COVID, who knows what people are doing. But this was showing the emission spectrum of the e-reader and how it was had a peak of blue that was very close to what we think of in terms of both potential eye damage and circadian rhythm. And basically, they had this long duration of blue light from the e-reader, or in some cases from a non-e-reader. And we're not sure that we can really extrapolate all those results to other ages, but it could be something we could study more. And maybe during COVID, it might be an interesting study, because people are on their devices much, much more now, and children are on them all day with home school. What about blue blocking glasses? Those that did wear them did find that they did better. And what they did is they had some subjects wearing clear lenses, others these blue blocking lenses, and then they reversed it. And the blue blocking lenses, you can see the clear transmission is that straight line across the top. And in the blue blocking lenses, there was a lot less, obviously, in the blue end of the spectrum. And so they did a crossover study, and what they found was that if they use the blue blocking lenses, they were sleepier in the evening when they should be, and that melatonin levels were less in those if they had the clear lenses on. They said morning sleepiness was not very different in the two groups. And this is from Esselor, who's kind of been leading the charge on that. And, you know, they now call it photobiology research. Again, they're the ones, I think, talking about it, this high energy light. I think it's important for us to understand all this, but I think we're especially scaring people, because basically I don't feel that there's an issue in terms of the effect in terms of macular degeneration. I don't think it's the main thing with eye disease. I think a lot of it is diet. And the other is that it may be helpful in front of a computer screen. I do know that I've had a number of patients and even friends who have tried blue blocking lenses and felt they were helpful. Exactly how they're helping them, I think, is unknown. I wonder sometimes if it's also because maybe their blink rate is better or something like that. But I do have a number of people who have said they really can tell the difference when they're wearing them or not wearing them. So if we want to talk about it potentially for comfort at the computer, that's great. They don't block all that much of the blue. I'll show you that in a second. I have just a few more slides, but also I worry, are there any negative long-term effects from even blocking part of the blue spectrum? I'm stuck here, hang on. There we go. So how much protection? Well, the purple here is the blue light hazard. The green is the melanopsin, and this black line is one blue blocking lens from Zeiss. And you can see that it does take a little bit off in the blue end, but not really all that much, which is good because we'd all be dead if we took away all the blue. So it drops to about 80%, but it's also well away from the peak of both the sensitivity curve, and I'll go back, of both blue light potential hazard in terms of macular degeneration. Remember we said like 435 and 465 for melanopsin regulation. And you can see that where the blue is the lowest is not quite at the peak of either one of those, which is kind of interesting. And so at the peak of melatonin sensitivity, now it's only about a 10% difference in transmission. And so when you do the math, you're getting about a 3% reduction in melatonin reduction. And so a 3% effect. And so is that worthwhile? Should we be telling everyone that they need these lenses? And so we do know that blue light can suppress melatonin. We know that it has this effect on sleep. The connection of blue light and these cancers, they say, remains speculative, but there was a researcher, he's passed away in the last year or two, who I heard a number of years ago, who had been doing quite a bit of research on this extraneous light at night and showing the connection to the breast and prostate cancers. And I think these lens coatings are of questionable value certainly if we're talking about eye health. Maybe there's something to it in terms of the computer screen, but if that's important, why don't we put it on the computer screen and then not be wearing it when we're not on these devices? And so here are just some questions. Is the light helpful or harmful? When is it helpful? When should we avoid it? Should we recommend either the blue blocking eyeglasses or intraocular lenses? And in general, what about different lighting recommendations for people? Or should they also be wearing it in eyeglasses, or should we be doing more on the screen? And I haven't tested it, but there is a free software out there called f.lux, and it will change the coloring of your screen depending on the time of day. So I'm going to test it at some point to see how much blue it's blocking or what it's really doing. But that's something that could be available to everyone and not something that's there when they're not on these devices. So I say thank you and let the sun shine in, and I'm open for questions.
Okay, thank you so much, Doctor, for such a wonderful question. So I'm looking for the question. Let's see if there is any. And I'd like to request all the participants to drop a question.
Yeah, you can put them in the chat if you want, and then I can read them off.
Yes.
And again, if you want to, let me know anything about how it's been talked about there, or whether blue blocking lenses are something that you talk about a lot there. I imagine you talk about sun protection, especially at the higher elevations, but how many people have access to that and can afford that? We have some of those issues here for sure. And so we need to make it less expensive, and we need to make it convenient if it's important.
Okay.
So any questions? I see we have somebody from Australia. Welcome.
Yeah, doctor. So we have also something called blue blocking lenses, blue light protective lenses excessively marketed here in Nepal also. Okay, I think same situation is all over the world.
Yeah, I think so. I think all these companies have that. Oh, and thank you. Someone put in the chat the f.lux. Can I talk about photobiomodulation? Well, basically, red and near infrared light has been shown to be used for a number of conditions. Athletes use it for recovery. It has been used with pain. It's certainly used with skin issues. It has been shown to be helpful in healing. I know that there are many, many red light devices out there. Some of them are pads, some of them are boxes that have red and near infrared light. Some people make them so they cover a whole wall so they can stand in front of them. And you hear a lot of anecdotal evidence that they're helpful, but there certainly is a lot of research to show that it is beneficial in terms of some of the things that we see in optometry. And also, I think more will be coming out in terms of the best way to get it through the skull or maybe through the nose, or I know there's been some research through the ears, but to get it more into the brain, because we do know that it can potentially be helpful in brain injury patients. But if you look up photobiomodulation, I think what you'll first see are a lot of websites pushing it for the cosmetic aspects of it. But I think we want to be more thoughtful in terms of how it can help our patients in terms of various conditions that they come in with or that we may diagnose. And the other piece is to really be thinking about this green light piece in terms of migraine. I had always used sort of blue or blue-green, for example, syntonic phototherapy with migraine patients, but maybe some green lighting in their home or near where they're working, or maybe even lenses that allow more green to come through to them may be beneficial for someone where other ways of treating the migraine either haven't worked or they would like to become less dependent on medication. Light is really a medicine, and we need to talk about it that way. And it's inexpensive, free if you go outside, and it's something that is natural. So we should be thinking about it. There's another question. When do light therapy, when does hue or intensity matter? Well, we do know that the color of light can be both narrowband and broadband. And there certainly has been talk about, we'll call it a little bit more narrowband if we're staying, let's say, within the red or the near infrared. But most light devices that I've come across, except for one that I happen to have here, the colors are not very pure color lines. So they tend to be fairly broadband, although they are one color. So if you have a blue, it still may be over a variety of wavelengths, obviously not 700, but it might go from, 400 to 500. It's not just 450, or it's not just 670, or some of the, there was some recent research with red light at a particular wavelength for cataracts. And I did get a bulb from a company out of the UK that they say has a peak at that same wavelength, but will that turn out to be absolutely necessary? Can we do it more broadband? I mean, syntonic phototherapy has been around for close to 100 years, and at least formally for 100 years. I think if you look back in older literature, you'll see that light was used in other cultures as well. And all of that lighting is broadband, it's not narrowband. So I think that intensity may matter. How close you are to the light to get the effect. For example, in white light therapy, they talk about using it for seasonal affective disorder, when you tend to be more depressed in the wintertime when there's less light hours. And they talk about 10,000 lux. And so I see here a lot of instruments where they market them and they say, this product has, 10,000 lux. And then I want to say, well, where does it have 10,000 lux? Do I have to be 10 inches from it? Can I be 20 inches from it? Because it's interesting, in the marketing, they'll show someone sitting at their desk with the light maybe, a third of a meter away from them. And then you read the fine print and you find out, to really get the 10,000 lux, first of all, it has to be coming into their eyes. And if their head is down and they're working, they're not getting as much. But also, they need to be sitting maybe half that distance from the light to get the full 10,000 lux. So you do need to look at that. In syntonic phototherapy, we say that when we do various colors, that the total treatment at any one moment in time is 20 minutes. And if you look at a lot of therapies, you'll find that treatment times tend to be between 20 and 30 minutes. So somewhere along the way, that seems to be optimal for the human body. Whether you want to do some of these therapies more than once a day with some time in between, I think we need to do some better research to find out if that really is helpful. But you're right, more is not always better. Someone else is asking about different companies that sell the FL41 tints. Are they all equal, and how to decide? That's a very good question. I've just recently acquired some different FL41 lenses and tints, and I have a handheld spectrophotometer, and I want to sort of test them and see if they're all the same. Again, is it necessary for it to be more exacting in terms of the range that it's in? Or if it's a little bit to one side or the other of a certain range of frequencies, will that be okay enough? I don't know the answer to that, but I do know that, at least to the naked eye, when you look at FL41, at least originally, when I was able to get some samples of it a number of years ago, it tended to have kind of an amber color, sort of a little bit brownish. And when you look at, for example, the newer lenses from Theraspex or Eschenbach, I'm sure there are others, it's a little more pink. And so are the transmissions really different? And is it important that it be one or the other? Or could it also be that certain patients may react better to one or the other? I don't think we know the answer to that, but it'll be interesting to look at that, because if that's true, then we want to be a little more exacting in terms of the lenses we use in our offices to test and what we recommend for patients. The biggest thing that I do is, when I want to give any tint, I don't tell a lab to match it based on how it looks. I tell them to try to put it under a spectrophotometer if they have it, and match it that way. So I'll send an actual lens sample with the patient, or when I did dispense, I would send it directly to the lab to have them match it. But I think you're right. I don't know who's producing the tints there. Here we have a company called BPI. They're really pretty much the only tint company, and they sell a bottle of what they call FL41, and you mix it with water and it goes into a heated tint bath. And here I recommend 25% FL41 for indoor use and 50% outdoor. That's transmittance, not, that's tint, not transmittance. Depends which way you talk about it. One of the labs here does it the other way around. So if I want 25% tint, I have to tell them I want 75 because they go by the light transmission. I hope that was somewhat helpful. I think you want to certainly source it, any of these things, from reputable labs, from where what you get and what you see is consistent. The other is, I don't know the difference of the tint in terms of it being, for example, on polycarbonate versus CR39 plastic. I generally recommend CR39, not polycarbonate, for patients where I'm recommending, for example, the FL41 tint, because most of those patients are particularly sensitive. And I find that the chromatic aberration of the polycarbonate also can create symptoms for them. So I have them generally in CR39, unless they have a very, very strong prescription, in which case I may recommend a high index lens, but not polycarbonate. Any other questions?
Okay, doctor. Can't see any question.
One more
Yes,
question here.
yes.
Is syntonics, that's a very good question. Is syntonic phototherapy efficient to treat macular degeneration or Alzheimer's disease? I think that in terms of macular degeneration, we want to look at being preventive. And I think that we should look at macular pigment density. And I think people really need to look at their diets. The American diet for sure is terrible, and certainly is a contributing factor. We do know even that in terms of diet, they've shown reduction in macular degeneration just by eating a cup of spinach, raw spinach each day. I think that it can be a part of what we do, but I don't think it's sufficient by itself. And in terms of the Alzheimer's disease, it'll be interesting to look at this light therapy along with the sound therapy. But again, I don't think we'd be treating it with syntonic phototherapy. We may be more supportive with it for right now until we know more. And how do I decide which color or tint to use? Well, it turns out that patients are sensitive in different ways. And I was just on a conference this weekend where they said, well, maybe we shouldn't say that there's a tint for a particular condition, that we should say there's a tint for a particular patient, so that we're not stuck thinking that it's only one color or one tint that might work for someone. I do think, though, that sometimes it can get challenging for both the doctor and the patient if you're trying too many tints. So what I try to do is have 2 or 3 tints that I know are generally helpful for a particular condition. For example, brain injury patients, we tend to more often than not use FL41 or a 10 to 15% blue, or sometimes a kind of peach color, sort of a lighter amber color. And I will start with those tints when I'm testing the patient in terms of their sensitivity. If we're trying to test it in bright light, I try to take them outdoors when I can and test it there. If not, I test it in my exam room. And then if they don't respond to one of those that I find works most of the time, then I'll try other colors with them. But I think that if we're going to try every color, then it gets to be a bit much. The other is, if you're trying different tints, I would put one tint on, see how they react to it. And when you take it off, I would wait about at least 30 seconds before I would put another tint on, just so their system can go back to where it was. Are there webinars, journals, or books that we can get to learn more about syntonic phototherapy? There are. If you want to email me, I'm trying to get a group together. I have a few people in India who are interested, and we can probably set up some type of a little study group. There also is the College of Syntonic Optometry. And again, if you send me your emails, I'm working on having a very limited membership fee, and then you would have access to their library of materials. There are a couple of good books that have been written more recently about syntonic phototherapy and light therapy in general. But I think that if you want to learn more about it in terms of using it in your practices, then you probably want to have a class, and we can talk about that. Maybe we can even do one through Mero Eye for those of you who are interested. I can talk with Mero Eye about that. Someone is asking, will these kinds of lenses work in blind people? So in terms of blind people, we know that they can't always be transmitting the light, one, because they can't see, but also it may not be getting to the ipRGCs if they've been damaged in the person who's blind, and therefore they will not be getting enough of the light to go to hypothalamus for regulation of circadian rhythm. So it's not that you can't try tints with someone who is blind. It certainly can be helpful. But if we're looking at any kind of therapies, for example, bright white light or colored light to allow for circadian entrainment or for depression, they may not be able to take advantage of that depending on the kind of eye damage they have in terms of their blindness. And I can type my one of my emails here. In the chat, so you can have it. But someone is asking also about Goulden's daylight glasses during color vision testing. Those daylight glasses during color vision testing are supposed to simulate what's known as a Macbeth lamp, something that most of us probably have never used. I was at one of the optometry schools one day, and we were looking in a cabinet with some older equipment, and we came across one, and the younger practitioners had no idea what it was. A Macbeth lamp was a lamp that created a certain spectrum of light so that if you were doing color vision testing, the testing wasn't distorted by the type of lighting in the room. And so those daylight glasses are to be used during color vision testing. They are not for other things. Can they be used with Ishihara? I believe they can. I have not used them, but that's what they are. They are supposed to simulate with whatever lighting is in the room what it's like to use a Macbeth lamp, which I doubt even exists out there anymore. I certainly haven't heard of one in many, many, many years. Any other questions?
All right,
Well,
Dr.
I thank you for your time. I think we've gone about the usual time, and I will see you all again in a few days.
Yes, doctor. Yeah, in time. No. Okay. So I can't see the presentation on the chat box.
Can't hear you too well.
Yeah.
But